Dr. Sean Tierney here with Dr. Bretta at Dr. Goins' office here in Los Alamitos, Pacific Healing and Wellness. And I just want to talk a little bit about, anatomical problems, hydrodissection, so we just, not only doctors, but also patients can understand kind of what happens when people have headaches and upper cervical problems. So I want to talk about the nerves that come out in front of the atlas, the first vertebra here. And there's this complex of nerves that I call the C1 plexus. Now in the C1 plexus, you have your vagus nerve, your internal carotid plexus, which is your sympathetic chain, your hypoglossal, your glossopharyngeal, your superior laryngeal nerves. And if you can follow it back with digastric, the facial nerve. So you have this plexus of nerves that often is irritated if you have inflammation or infection or injury in that area. And it's a devastating problem for a lot of people, because if you throw off your vagus nerve, you irritate your vagus nerve or your sympathetic chain, you can have high blood pressure, low blood pressure, POTS. You can have low heart rate, high heart rate. All of these things are very difficult to deal with. And it's just because you have adhesions or a lack of motion due to inflammation in that area at C1. So C1, what could the symptoms be? What could be your heart rate. It could be that you feel like not as focused. The facial nerve controls the tone of your eardrums. You could have like a loss of hearing, a pressure feeling in your ear, controls the pressure of your middle ear. So you can have that kind of congestion in the ear. You could have some upper cervical instability, because the other thing that happens at C1 that I would add to is the occipital nerve, which is actually the nerve root of C1 becomes the occipital nerve. And the occipital nerve controls the upper cervical musculature. Now the upper cervical musculature is suboccipital muscles. So we have the inferior oblique, the superior oblique, the rectus capitis posterior minor and major, and you have your rectus capitis anterior, all controlled by that occipital nerve. Now, there's a lot of talk and a lot of work on this upper cervical instability. A big portion that's not addressed is this paralysis due to this C1 plexus or that occipital nerve dysfunction. So what I want people to understand is that there's the focus on ligamentous structures and there's focus on muscles, but the truth is if you're in a surgery and you're under anesthesia, you have no muscle tone. And if somebody were to turn your head, you would probably have some dislocations there, because the major stability of your head is these suboccipital muscles. So without those muscles functioning, you have major upper cervical instability. So the importance of C1 occipital nerve, so far as upper cervical stability, is really underestimated. So what we do is with that area is we can, as these nerves move, and I just think nerves have to move a lot, and nerves are at least the size of tendons. So these nerves need to move as he moves his neck. Now, the reason that there's so many nerves here is this is the minimum amount of motion that would happen to a nerve coming from the head down to the body. Now, to give you now, some nerve that's not as advantageous, how much motion would be the greater occipital nerve. So I want to talk about the greater occipital nerve. Now, unlike C1 that comes out right where the least amount of motion coming down into the body, where the nerves have the least amount of stretch, the greater occipital nerve comes out between C1 and C2 in the ponticles, between C1 and C2, and it loops all the way to midline and then all the way back over, and then it goes back around, and that can be one of the nerves that causes a headache. Okay, so that nerve comes out between the ponticles all the way to midline, all the way back over, and all the way back up. And we can see that with ultrasound. Why does that nerve do that loop? It's very simple, because whenever he turns his head this way, there is no loop, it's a straight line. So that nerve needs to, and that's going between muscles, so that nerve needs to have the mobility to move through those muscles. If you have inflammation in that area, and you throw webs or fibers between those muscles, now the nerve is restricted in its ability to move, and you have a headache that's chronic, potentially. So what happens is we can hydrodissect. We can just separate the muscles and break those adhesions just using water pressure with a gentle injection. And then now the nerve is free to move whenever he moves his neck. If you didn't do that, what you can do is you can massage the area, you can do therapy, you can do exercise, and it feels better for a day or two, sometimes longer. But if you still have those adhesions there, a slight amount of muscle tightness gives you a major headache, right? And I would also add that it's not just the nerve, there's also arteries in there too, so sometimes it'd be a throbbing headache. So that's, if somebody has a headache, it's one of three nerves that actually causes the pain of the headache, unless it's from the brain, which is very unusual. So that 99.9% of all headaches that come from one of three nerves. One is the greater occipital nerve that does one of these, and the second one is the lesser occipital nerve. So greater occipital nerve comes between C1 and C2, and the lesser occipital nerve comes out at C2. So there's also what I call, this is C1 plexus, and there's a C2 plexus. It's really part of the cervical plexus, but C2 is a pretty big area too. So let's think about the nerves that are coming out of C2. You have the transverse cervical nerve coming down, going to this point. You have the greater auricular nerve that's going to go down to C6, wrap around, come out the SCM here, and then wrap back up and cover this whole face. That toothache pain people get is because of that nerve. Now, the reason that you have that toothache pain with that nerve is that you have an infection and the lymph nodes are draining under this SCM. So that infection drains down, irritates the nerve, and it causes the pain. So the pain actually that you get right where my hand is touching with the toothache is actually that greater auricular nerve. And it's caused by the infection because you get adhesions in this area and lymph node enlargement in this area. But taking care of the infection doesn't necessarily clear it because it's a nerve problem, and the infection is probably in the jaw, right? So you got addressing both actually solves a problem. And a lot of times, if you have this severe toothache pain, do the hydrodissection, instantly the pain is relief. You still have to go and get your infection treated. So you still need to see the dentist, but we need to address that area. So I'm looking at this greater auricular nerve. It's going to come out at C2. It's going to go all the way down, wrap around underneath the SCM, where all the lymph nodes, cervical chain of lymph nodes is, and go back up to the jaw. There's another nerve called the lesser occipital nerve that does the same thing. It comes down, wraps around, goes back up, and it wraps around the longissimus here, and it goes back up and causes a headache. So that's the second nerve. It comes from C2, not to ponticles between C1 and C2, which is called the lesser occipital nerve. So it's going to come out of C2, go all the way down to C6, wrap under the SCM, come back up, wrap around the longissimus capitis with the occipital artery, and then follow all the way around and potentially cause a headache. So if you have a greater occipital nerve problem, then you're going to have a little bit of a muscle spasm or irritation right here more medially in this medial tissue. So that's going to be a headache that's associated with that is probably going to be the greater occipital. And a headache that's associated to this longissimus capitis is just like right underneath the trapezius here, where there's a bundle of tightness right there. That would probably be the lesser occipital. So when we understand what we're dealing with, we can get a better treatment. Whether you're doing a hydrodissection, which can be very effective, or you're doing ART or whatever therapy, to know what nerve it likely is, it does help with getting a better result. So we know we have to deal, if we have the lesser occipital, we know we have to deal with the SCM. We know we have to deal with potentially an infection or adhesions in the sympathetic lymphatic chain, and we're in the cervical plexus. The other thing that happens here would be the third occipital nerve. So there's greater, lesser, and least. The third occipital nerve is often called the least occipital nerve. And it also comes from the C3 nerve root. It's the same thing. It's part of the cervical plexus, and that nerve is going to go down, and it's going to go. It's going to come out, and rather than going down around the SCM, it's going to shoot straight back. It's the smartest nerve of those three. I just say that because there's the least amount of torque that's going straight back. So when you turn, it's not going to be stressed as much, and then it just goes straight to midline and then straight up over. So greater, lesser, and least are all cause this like pain between the eyes, this headache where my hand is, right? Greater, lesser, and least occipital nerves cause that. So in chiropractic, there's a whole chiropractic, is obviously successful practice. There's a whole section of chiropractic. All they do is focus on C1, and knowing what the nerves that are involved there at C1 and C2, it kind of makes sense why that works. I don't think it's a good idea to focus on one small little thing like that, but it is an effective treatment, and has been. Now that we have, diagnostic ultrasound and the ability to do hydrodissection, we can be even more precise. And we can also do that hydrodissection at C1 for this post-COVID type symptoms, which would be, alterations in hearing, taste, smell, focus, blood pressure, heart rate. All those irregularities happen with the post-COVID for some reason, and I don't know what, but any infection, you can still get that C1 plexus irritated. COVID, sometimes even the vaccine, tends to irritate it more, right? And it's real. We see that problem a lot. Perspective of what the percentage is hard to say, but it does happen, and there is a really good treatment for it. Okay, so I just want to understand how much the nerves move and how much an adhesion in this area can be an issue. So there's the cervical plexus, which is mostly C2, 3, 4, that are innervating those nerves: the transverse cervical, the greater auricular, the lesser occipital, and then also the supraclavicular. So the supraclavicular nerve is part of the brachial plexus. Are part of the cervical plexus. This is probably C2 branches of the supraclavicular over the chest, C3, C4, C5, and C6 coming all the way around. Ironically, these posterior supraclaviculars don't actually cross the clavicle, but they're still called supraclaviculars. And then we have nerves of the brachial plexus that are coming back this way as well. So as the nerves in the brachial plexus, which is primarily C5, 6, 7, 8, and T1, as C5 comes out, there's a nerve that comes off it almost immediately called the dorsal scapular nerve. It's going to come down, wrap over the first rib, and wrap around the underneath the levator scapula, and come down and run right between the shoulder blade. So when you have this pain, interscapular pain, that's closer to the shoulder blade, that's probably coming from the neck. If it's coming right over by the center of the spine, maybe coming from the mid-back. It's a lot of motion and a lot of places where the nerve can get caught, especially because we know there's also another plexus called the subtrapezius plexus, and a nerve that comes out here at C1 as well, called the spinal accessory nerve, that's going to run under the trapezius and be over the levator scapula, between the levator scapula and the trapezius, and come down between the shoulder blades. So the issue that one thing is there has to be a lot of motion. Imagine how much those nerves have to move to travel that distance. If there's a restriction or adhesions or webs between the muscles that kind of catch the nerves so they can't move, without a hydrodissection or sometimes maybe even a surgical dissection, you're not going to get a solution for that. So we want to be aware of all the motion has to happen. So a lot of times it could be anywhere from C5 coming across here, C6, C7, C8, giving you that interscapular pain. Now, most of these nerves, a lot of the brachial plexus is going to come down the front into the axilla and into the arm, causing numbness in the fingers. This would be C6, middle finger, and half of this ring finger would be C7, and half of the ring finger here and this side would be C8. So we have all these nerves, and when you move your neck, those nerves really have to stretch and move between muscles. So there's often this impingement of those nerves with underneath the SCM between the scalene muscles, and we can hydrodissect those. So now I talked about all of the cervical plexus, which is going to be your supraclavicular nerves, your transverse cervical nerve, your greater auricular nerve, your spinal accessory nerve. There's also a nerve called the phrenic nerve in there. The phrenic nerve, as we would say from anatomy, it's like C3, C4, C5 keeps the diaphragm alive. It's a very common issue to have a phrenic nerve problem, and that interferes with the normal balance of the diaphragm. If the diaphragm is in balance from one side to the other side, we tend to get a little bit of abdominal content potentially getting into the chest cavity called a hiatal hernia. And so people may have heartburn. They also may have a lot of abnormal torque on their thoracic lumbar area, causing them to have kind of lateral anterior hip pain. And all that is coming from the neck. And then we see that a lot of times with kids, because they have chronic infections, kids can get a lot of lymphadenopathy, lymph pathology here under the SCM that can affect the phrenic nerve. So we're thinking about the phrenic nerve, we're thinking about the transverse cervical, the supraclavicular nerve, and the greater auricular nerve, the lesser occipital nerve, cervical plexus nerves. Now, all those nerves are the ventral rami, the front side of the nerves coming out of those levels. The nerves coming out of the backside become the subtrapezius plexus. You know, as a web of nerves that are not really even named very well, but they go underneath the trapezius, and that's another level of irritation of nerves that we could have. So this subtrapezius plexus is secondary. It's going to these interscapular nerves. That's also in the interscapular area under the trapezius. So that's that subtrapezius plexus, and let's not forget about that. A lot of times we do have to hydrodissect underneath the trapezius, and also go back to the nerve root where the actual injury is. The nice thing about ultrasound is I can look at a nerve root exactly and push directly on it. So I can kind of say, hey, is it sore here, here, here with the probe? And I can know I'm pushing on a nerve root. So a nerve root that's irritated a lot of times is very tender. So I kind of know, okay, I know I have pain back here. I can get a good idea of where the problem is. Sometimes if the nerve is severely irritated, it gets enlarged. If it gets enlarged, it's actually been damaged, so we don't really want to see that, and we don't have to see that to treat it. But an enlarged nerve is damaged, and an enlarged nerve in the cervical or brachial plexus is usually not a good thing at all. So sometimes not recoverable. So that's our summary of these nerves. So when you have a headache, you want to think, is it the greater occipital nerve? Is it the lesser occipital nerve? Is it the third occipital nerve? You can kind of, so this semispinalis, which is underneath the trapezius here, and that's where the nerve has to take a turn through. So that would give this little tight band here. That would be greater occipital, little tight band, and more on the outside of the trapezius here. That's the longissimus area would be the lesser occipital, and then right in the middle would be like kind of the supraspinous ligament would be the lesser occipital, and the least occipital nerve coming around. So we have three nerves that cause headaches, and another additional nerve can cause instability, and then we have all these plexus of nerve that we need to be aware of, and when we approach the neck. All right.